Good afternoon, everybody, and welcome to the webinar. Today, we are in the Stay in Care series, and we're going to be talking about demystifying congenital valve disease. We're going to go back to basics. Just a few housekeeping rules and notes before we start. All attendees are in listen-only mode. If you cannot hear, hopefully you can see the slides, and you'll be able to check the audio button on your personal computer to make sure that the sound is on. That's typically the problem. Please type your questions into the question and answer box at any time during this presentation, and the moderators will read your questions during the question and answer period. So you don't have to wait to put your question in. Just know that at the end of the presentation, we will get to it. And finally, a PDF version of the slides, as well as recording of the presentation, will be available on the Mended Hearts website following the event. Just a little bit about Mended Hearts. We appreciate you coming and joining us today. Mended Hearts is a national community-based nonprofit organization whose mission is to inspire hope and improve the quality of life of heart patients and their families through ongoing peer-to-peer support, education, and advocacy. We'd like to give a special thank you to Medtronic for the educational grant that has made this webinar and others possible. I am Andrea Baer, the Executive Director here at Mended Hearts, and I am joined by Jody Smith, the National Program Director of Mended Hearts, and we will be the moderators for today. So now I'm going to introduce Dr. Henry Justino, who has been fabulous to join us today. Dr. Justino is a board-certified pediatric cardiologist with over 20 years of experience in clinical and interventional cardiology. He is a tenured professor of pediatrics at Baylor College of Medicine, director of cardiology intervention and co-innovation, and co-director of the Mullins Cardiac Catheterization Laboratories at Texas Children's Hospital. He specializes in cardiac catheterization and interventions in children and adults with congenital heart disease, including transcatheter valve replacement, stent replacement, closure of atrial and ventricular septal defects, and has a special interest in complex cardiovascular anomalies. He is actively involved in several clinical trials with novel medical devices and has founded a startup company, polyvascular.com, devoted to developing heart valves for children and adults with congenital heart disease. Dr. Justino, thank you so much for joining us today.
Well, it's great to be here. Thank you so much, Jody, for the introduction. I'm going to go ahead and share my slides here. The goal of today's presentation will be for us to discuss some basics of congenital heart disease, especially when it comes to valve conditions. And I'm going to go ahead and start my presentation. The goal for me will be to try to balance the too much detail with too little. I could spend an hour and discuss every single kind of heart condition, and I would only get to spend 5 seconds on each one, and that really wouldn't be helpful to anyone. Or I could do a deep dive on only 1 or 2 heart conditions, and some of the families would find that helpful, but others wouldn't find it relevant for their situation. So what I thought I would do is talk a little bit about the basics of valve disease, talk about some detail in some of the heart conditions, but really try to give a broad overview, and then leave some time at the end for questions. And hopefully this is just the beginning, and there'll be other opportunities for us to do a deeper dive on more specific heart conditions that some of the families may be requesting for us to look at. So I'll start by demystifying congenital valve disease. These are my disclosures here. So I will review the basic cardiac anatomy and function as it comes to the heart valves, discussion of the normal heart valve function, and then talk about what is valve dysfunction or abnormal function of a heart valve, which can consist of stenosis, regurgitation, or the combination of both. We'll talk about some specific valve disorders and treatment options for those valve disorders, such as surgical repair or replacement, or catheter-based repair or replacement. And we'll talk about at the end a little bit about the importance of why you should stay in care if you have a heart condition. And that's kind of the theme of the webinar today. But in order to help you understand why you need to stay in care, let's talk about what exactly are heart valves. So the basic anatomy and function of the heart. Many of you are already very familiar with this, but it's worth spending a few minutes on this. The heart is really made up of two pumps, one that takes the blood from the body and sends it out to the lungs to pick up oxygen. And then the blood returns from the lungs full of oxygen and gets to a second heart pump, the left side of the heart, and that pumps the blood from the lungs out back to the body. Now, what exactly are heart valves? Why do we have them? And what would happen if we didn't have heart valves? Well, let's imagine what a heart would look like if it didn't have any heart valves. Let's begin with the concept of a tube with fluid inside of it. For example, a garden hose that has water on the inside of it. If you wanted to move water along in this hose, you could develop a little bulge in the middle of the hose. Imagine you have a chamber in the middle of the hose that's flexible, that can be squeezed. That might help move fluid along in this garden hose. Now imagine that bulb that's in the middle, or that bulge, is like one of these pair bulbs here that we will take and cut off both ends of the bulb so there's an opening, and glue it or sew it or attach it in some manner to both ends of a garden hose here. Now fluid could travel from one side into the bulb and out the other side. So if we were to now squeeze that bulb in the middle, this is what would happen to the fluid in the pipe or in the garden hose. We would squeeze down the bulb and fluid would rush out toward the right, it would rush out toward the left, because fluid could really exit both sides of that bulb. When the bulb relaxes back out, and these arrows outwardly are designed to show that the bulb is reinflating itself, the opposite would happen. There would be suction of fluid back inside the bulb, and that would refill the bulb. So really, at the end of the day, we could squeeze that bulb as often as we want, and we wouldn't really be moving fluid along the pipe or the garden hose at all, because fluid would come out when we squeeze the bulb, and it would suck back in when we let the bulb reinflate itself. The next time we squeeze it, it would come out again, and then it would just come back in again. And the fluid would just be going back and forth like this, and it wouldn't actually move anywhere useful. So this kind of valveless bulb tube heart that we've developed here would be very, very inefficient. The blood would never get anywhere, or the water or the fluid. So that's what the purpose of the valves is to help to direct the blood in the heart. The valve, any valve really, has only two jobs. It's got to open well and it's got to close well. And the valves really exist to allow flow in only one direction. So by adding two valves to our bulb tube heart that we've developed here, we can establish flow in one direction along this garden hose. So we would need one valve on the way into the bulb, which we will call our inflow valve, and then we would need another valve on the way out of the bulb, which would be our outflow valve. And that's what this could look like. So this is a garden hose coming in, this is that bulb in the middle, and this is the other part of the garden hose coming out. If we install a valve which has these flaps here like this on the inflow, and another valve with flaps on the outflow of the bulb, this is what would happen if we were to squeeze the bulb down. As we squeeze it down, the pressure that develops inside here forces this valve to close, because the flaps are pointing in this direction, and it would force that valve to close, and the fluid could not move to our left here on the diagram. But it would actually force the valve to open on the other side and force the fluid to come out. And so this would establish flow coming out in this direction. Now, what happens when the bulb reinflates itself? When the bulb reinflates itself, the suction that is created draws in fluid from the left side and blows open this valve so that fluid can come in and reinflate that bulb. At the same time, the same suction is also tries to apply itself to the outflow side, but because the valve points in this direction like this, when there is suction, it forces the valve closed. And now the blood or fluid cannot come back into the bulb from this direction. So this would be a very efficient system where we could squeeze the bulb, force the fluid out this way, and when it reinflates, it never reinflates back from this side, it always reinflates back from that side. Now this amount that's just come in from this side can be squeezed and sent along this way again. And when it reinflates, it brings in the next amount of fluid that needs to be drawn out again and pushed out that way. So this becomes an actual efficient pump. And what we've developed here is more than just a bulb tube kind of system. This is actually an artificial heart. That's how an artificial heart can work. And some work in this principle of a bulb that squeezes down, forces fluid in one direction, draws it in on the next reinflation from the other direction. So once we have two valves in there, now the pump is very efficient and can move the fluid from one direction to the other. And again, it establishes the flow in only one direction because of the way the valves are aligned and open in one direction only. Now, how does this exactly apply to our heart? Well, our heart has two of these exact type pumps, which are, one of them is called the right heart and one of them is called the left heart. So even though we say the heart is a pump, the heart is really two pumps working side by side. And each of those pumps has to have two valves, an inflow valve and an outflow valve for each pump. So the right side of the heart has an inflow valve that leads to the pump itself, which is the right ventricle, and then an outflow valve that leads to the pulmonary artery. And on the left side of the heart, once the fluid has been moved from the pulmonary artery through the lungs to the left atrium, now the left atrium sends blood into the left ventricle. The left ventricle is the bulb of the left side of the heart, or the pump itself, and it has an inflow valve and an outflow valve as well. So if we look at a more realistic sort of view of what the heart looks like, this is what we see. This is the tricuspid valve, which is the inflow valve of the right side of the heart. This is the pulmonary valve, which is the outflow valve of the right side of the heart. And the bulb is this blue chamber right here, which is the right ventricle. And then on the left side of the heart, we have the inflow valve, which is the mitral valve that allows blood into this pump, or the bulb on the left side of the heart, which is the left ventricle. And then the outflow valve that allows the fluid to come out of that second bulb on the left side of the heart, and that's the aortic valve. So let's now look at a diagram like this of the normal heart. The normal heart can be drawn in this way, but it is complex and it is a three-dimensional structure that we flatten into a two-dimensional cartoon. So sometimes it creates a little bit of a perception that's difficult to understand in the heart, but we'll try to go through this step by step and describe the different parts of the heart and the different heart valves. So again, this is the tricuspid valve, which is the inflow valve of the right side of the heart. This is the pulmonary valve, which is the outflow valve of the right side of the heart. This is the mitral valve, which is the inflow valve of the left side of the heart, and the aortic valve, which is the outflow valve of the left side of the heart. Okay, and as we've drawn here now, I've made these arrows blue to indicate that the blood is blue because it's lacking oxygen, and red on the left side of the heart because the blood is full of oxygen. And when oxygen attaches itself to the molecules in our red blood cells, the red blood cells turn into a bright red color. If we now label the other parts of the heart itself rather than the valves, we have the right atrium, which is the inflow portion that leads to the inflow valve of the right side of the heart. The right ventricle is the pump itself. The pulmonary artery is what the right ventricle is pumping into. It's that garden hose on the outflow of the right side of the heart. And this garden hose leads to the lungs to pick up oxygen. So the blue blood enters the lungs, circulates in the lungs like this on one side and on the other, and then returns through these veins here. And these veins bring blood back to the left side of the heart. And it receives, in this receiving chamber, the blood enters, which is called the left atrium. Then it goes through the inflow valve into the left ventricle, which is the pump itself of the left side of the heart. Then the left side of the heart, the left ventricle pumps the blood out, full of oxygen, out to the aorta. And the aorta is the garden hose on the outflow of the left side of the heart that distributes the blood all the way down to the body, all the way to our heads, all the way down to our feet. And all that blood, once it's given up its oxygen to the parts of the body, it will return coming down this way into the right atrium, and it's from the feet also to the right atrium. I apologize, I will mute myself here for a moment.
Call from 1248.
let's go ahead and move on to looking at specific valve disorders now. So the valves, as I mentioned, really only have two jobs. They've got to open well and they've got to close well. That's all there is to it. And those flaps that we've described that open and close, that's all they have to do. Notice there's nothing in the valves that makes them open. It's not an active opening like an electric door. It's really a passive opening that's blown open by the pressure of the heart, and it blows itself back to being in a closed position when the heart relaxes. And so let's talk about what happens when a valve doesn't open well. And this is where we have to kind of demystify some of the jargon. You have to forgive us doctors because we like to use big words because big words make us feel important. So stenosis is just a big word to describe a narrowing, something that's not as large as it should be. And we say a valve is stenotic when it's narrowed. That means the valve, instead of opening all the way like this, it opens only part way like that. And so the actual opening that the blood can come out through is a much smaller opening than if it were opening all the way. When valves don't close well, we have to use another complicated term. We call that regurgitation or insufficiency. Sometimes we have to use two terms that mean the same thing, but are both complex just to make ourselves feel even better. So regurgitation or insufficiency is when a valve fails to seal well when it should be closing. So a valve that closes should have a good seal, and there should be no blood leaking back this way. But if the valve, instead of closing well, it leaves like a little gap in the middle like this, you might see it like that. Instead of closing like this, if it left like a little gap in the middle, then blood could leak its way back through. And so that would cause insufficiency or regurgitation are the terms that we use to describe that. I will bring up a term that we use in congenital heart disease, which is a valve that doesn't exist at all. There's no opening of any kind, so it can't open or close because it doesn't even exist. That's a valve that has atresia, where you say atretic. So that valve never developed, doesn't have any kind of opening to it at all. Now, the causes of valve disorders can be various types. So congenital valve disorders are what we're going to focus on today. And we would use the term an isolated valve problem when it exists by itself. That is the only problem in the heart with no other problem anywhere else. However, congenital valve problems don't just exist by themselves. They can also exist as part of if you will, a package of other kinds of heart problems that go along with having a valve problem. And those could be problems in other valves of the heart, or it could be holes in the heart, or some underdevelopment of some of the heart chambers, for example. Now, those are all the causes that are congenital, where you're born with the valve already abnormal. There are people who are born with a completely normal valve, but they acquire a heart valve problem later on. They develop it during their lives. That's called acquired valve disease. And the most common cause around the world of acquired heart disease is rheumatic heart disease. It's a real rampant problem throughout low and medium income countries, but it's a problem that's been largely solved in high income countries, because it is known to be caused by strep throat. So strep throat that goes untreated, especially if multiple episodes of strep throat, can lead the body's immune system to overreact to these strep throat episodes and eventually attack the heart itself because of mechanisms that are a little bit too difficult to go into right now. But the heart valves can become destroyed as a result of multiple episodes of untreated strep throat. And as simple as it is to take treatment for strep throat, which is just penicillin that works still around the world, the reality is that many people don't have access to that. And that's the cause of their development of heart valve problems. And that can happen in childhood, in adolescence, or throughout adulthood. And it is the most common cause of heart valve conditions throughout the world. Endocarditis is another type of acquired heart valve problem. It's a direct infection of the valve tissue itself, unrelated to strep throat, completely different issue altogether. It's when bacteria enter our bloodstream and land on a heart valve and cause a development of pus on the valve itself that destroys and eats up the valve tissue and makes the valve not work well. So a bacterial infection of the valve tissue is called endocarditis, okay? And that's another type of acquired valve disorder, if you will. So now let's go step by step and go through all of the different heart valves. And I will really focus mostly on the right side of the heart today and touch only a little bit on the left and really only on the aortic valve, because I think that we should spend a little more time and a little more detail on these, and then we can always have another opportunity to discuss other heart valves or other heart conditions altogether. So congenital disorders of the tricuspid valve as an isolated problem, nothing else wrong with the heart, only the tricuspid valve as a problem, is actually quite rare. There's something called Ebstein's anomaly, where the valve, instead of attaching in its normal location, can attach way down inside the right ventricle, and that usually causes severe leak of the valve because it can't make a good seal. Another type is called tricuspid valve dysplasia, which is just an abnormal development of the valve tissue itself, of the tricuspid valve, and often it does have a lot of leak as well. Those are isolated problems of the tricuspid valve without any other heart problems present. As opposed to the leaking issue, there can be tricuspid stenosis, which is narrowing of the valve where the valve fails to open well, but that is unbelievably rare as an isolated problem. It's almost always present in the setting of having other heart problems, including, for example, an underdevelopment of the right heart that has pulmonary valve problems as well, such as pulmonary valve stenosis or atresia, okay? Now, tricuspid valve disorders, if they do occur, can also be acquired later on from endocarditis. Rarely, very, very rarely is it caused by rheumatic heart disease. Tricuspid leak, if there is a lot of leak of the tricuspid valve, could require tricuspid valve surgical replacement, putting in a brand new valve in there. Fortunately, that's a rare problem, but it does happen. And nowadays there are some developing, they're not quite ready for prime time yet, but there are some developments happening as we speak on catheter-based techniques to treat leaking of the valve to help it make a better seal. But for right now, the standard of care is a replacement of the heart valve with an artificial heart valve. Tricuspid stenosis, again, because it's not something that occurs by itself. It really occurs as part of a broader kind of heart problem with other parts of the heart being affected. It's not that we treat the valve by itself. It's when we're treating the rest of the heart that then the tricuspid valve becomes part of the treatment as well. Let's move on to pulmonary valve disorders. So that's the valve right here, which is again the outflow valve of the right side of the heart. Pulmonary valve disorders are actually very common. Pulmonary valve stenosis, where the valve fails to open well, is actually, as an isolated problem, one of the most common heart conditions that we encounter. And the treatment for a valve that is kind of stuck and does not open well is a balloon pulmonary valvuloplasty. That's where we go in the cath lab under anesthesia and put a small catheter in the leg or in the neck, for example, and thread a little catheter all the way up into the heart, and then go through the opening of the pulmonary valve and use a balloon to stretch open the valve. So what we're trying to do with that procedure is, if the leaflets of the pulmonary valve, and there are three, like 1, 2, and then a third one here like that, if the leaflets, instead of opening completely independently and well and separating from each other as they open, if they're fused to each other so that they try to open but they're kind of stuck because they can't separate well, we go in there with a balloon and inflate a balloon like this and separate those leaflets and cause them to kind of tear away from each other so they can actually open better, okay? And that's what a balloon pulmonary valvuloplasty does. Now, a balloon pulmonary valvuloplasty, and that's true for any balloon dilations of any valve, not just the pulmonary valve, always introduces the potential for a trade-off. When we are separating those leaflets and improving the way they can open up by allowing them to move away from each other rather than being stuck to each other, what can happen is that when the time comes for the valve to close on the next heartbeat, the valve may not make as good a seal anymore. And instead of making a nice seal like this, there could be a little gap like this that forms at the site where the tear has happened. And that can lead to leaking of the valve. So sometimes we end up with a trade-off where we go in to open the valve that is narrow, because we do need to open that valve if the narrowing is very severe, and we accept that we will have some trade-off and cause potentially some leaking. Now, fortunately, pulmonary regurgitation or leak of the valve, or again, the term can also be used insufficiency, is actually something that's really well tolerated. And it's something that can go on for years or even decades before it needs to be dealt with. So the body has a way of tolerating that very well. It's an interesting thing that if you look at the way we talked about the bulb and that kind of heart idea that requires valves to move blood along, it turns out that of all the 4 heart valves that exist, the pulmonary valve is the only one that we can actually live without. And the heart would still work quite well, not perfectly, but quite well. There is no other valve like that. We can actually cut away the pulmonary valve and leave someone with no valve at all, and they will live that way for decades. But if we tried to cut out any other heart valve and end up with no valve there at all, so that like the bulb, the fluid would just go back and forth and not be able to be propelled, we wouldn't live more than a minute without one of those valves. We couldn't survive that at all. But the pulmonary valve, because the lungs are very special in the way they can handle blood, they have very low resistance, blood flows easily into the lungs. We can actually live without an outflow valve because very little blood would actually leak back and the heart could still overall function quite well. So, however, when we do cause leaking of the valve, either because it's been cut out, the pulmonary valve can also develop leak, as we talked about when we balloon the valve because of narrowing and have that trade-off with leak. That leak, if it is severe and if it's gone on for many years or decades, may require that valve to be replaced altogether. And that replacement can be done with an open heart surgery to sew in a brand new valve, or with a catheter-based valve replacement, which we'll talk about in a minute. So this is an example of pulmonary valve stenosis, where the effective opening of the valve is like could be quite small, can even be like a pinhole at birth sometimes. And we go in there, and this is the little jet. This is a dye that we see injecting dye in the right ventricle, and we see the jet coming through right there. And that jet blowing through that opening is opened up with these balloons. Sometimes we can use 2 balloons together, especially in teenagers, when the valve is overall, the dimensions of the valve are large, even though the opening, the effective opening is small. We can actually put 2 balloons in there to open that up. So let's talk about other right heart anomalies. We've talked about the 2 valves of the right heart, the tricuspid valve and the pulmonary valve, but we've only covered the isolated valve problems of the tricuspid valve or the pulmonary valve. But there really are 2 other major ones, and I will mention that there are so many others that, again, we couldn't go into them all. But tetralgia Fallot and a close cousin of that, double outlet right ventricle, are 2 types of conditions that involve heart valves of the right side of the heart, but also do so with involvement of other more complex heart malformations. So this is, pardon me, this slide wanted to skip here. Before I get into that, I wanted to come back, and I apologize, this is out of sequence, but pulmonary atresia with intact ventricular septum. I will step away from tetralogy for a moment and just describe that in pulmonary stenosis, we had a pinhole opening as an isolated problem, but pulmonary atresia can also occur where you have actually a complete closure of the valve. There is no opening there whatsoever, and it is kind of an isolated problem because there are no other valve problems, except that it can lead to some element of underdevelopment of the right side of the heart. And in some cases, there are abnormal communications involving the coronary arteries of the heart as well, which are the arteries that actually supply the working heart muscle with nutrients. There can be abnormalities of the coronary arteries in pulmonary atresia with intact ventricular septum. And in this condition, it is sometimes possible to actually create that pinhole to open up that valve, and then same idea, use a balloon to open it up. I won't get into this much today, but I know it's an area of great interest to many families, which is talking about what is a 2 ventricle circulation versus what we call a 1.5 ventricle circulation versus what we call a single ventricle circulation, where people end up with a Fontan operation. That becomes relevant for this heart condition, but is also relevant for a whole host of other heart conditions that we won't be able to get into today. But that'll be the topic for another webinar in the future. So now let's go back to tetralgia Fallot and describe an example of a common right heart problem that is not isolated to the valves, but is also implicates other parts of the heart. So this is the most common cause of having a blue baby, or so-called cyanotic. Cyanotic from the word cyan, which is blue. Cyanosis is caused by blue blood that should go to the lungs and pick up oxygen, but in some way is not getting, all of it is not getting getting to the lungs, and a good deal of it is actually getting out to the body to make the blood circulating to our tissues not as red as it should be. And that's what gives that blue color to children who have certain heart defects. It's estimated that about 10 to 15% of all congenital heart disease is tetralgia Fallot. So it is a very common problem. When Dr. Fallot was a French physician who described what tetralgia Fallot is, what we now call tetralgia Fallot, because it has 4 features. Tetra is Greek for 4. And he described that patients who had this condition would have a hole in the heart, which is number 1 here, a ventricular septal defect. Ventricular septal defect because it is a hole, a defect, in the ventricular septum. Ventricular because it is in the ventricles, and septum is just the Latin word for a wall, okay? It's a hole in the wall between the ventricles. That's what a ventricular septal defect is. And that is the number 1 condition here. The number 2 part of tetralgia Fallot is the right ventricular outflow tract obstruction, the narrowing of the pathway out of the right ventricle. And you can see this is crowded and narrowed under here. Number 3 is the overriding aorta, which is basically that the aorta, instead of sitting solely over the left ventricle, kind of creeps over toward the right and is kind of sitting a little bit over the right ventricle and over the left ventricle as well. And 4 is the abnormal thickening of the right ventricle muscle, which is the wall of the right ventricle here, which is right ventricular hypertrophy. Now, this idea of these 4 main features of tetralgia Fallot still makes sense today, but it was actually better described in more recent years as being really a monology. And a monology means one single problem is really at the origin of tetralgia Fallot. And the monology theory describes basically this little hunk of muscle right here, which is known as the infundibular septum. And that's a part of the ventricular septum, again, that wall between the ventricles, that has become dissociated from the rest of this wall here. So normally during formation of the heart, the bottom part of the ventricular septum down here is supposed to join and meet up with this top part that comes in. But if it becomes separated, and in addition to separation, there's also a deviation of this part of the septum over this direction here, which is the part with the red asterisk, that deviation crowds this area here underneath the pulmonary valve, causes some narrowing, and also causes the overriding of the aorta because it drags the aorta over a little bit to be over the right ventricle, leads to the ventricular septal defect, and then the thickening of the heart muscle is just because the ventricles are operating both under high pressure because of the big hole. So that's, for those of you who are familiar with tetralgia Fallot and you've wondered what are these 4 things and what do they all mean, it really comes down to one main thing, which is the lack of proper union of the 2 parts of the ventricular septum during embryonic development. Now, at birth, patients who have tetralgia Fallot, the reason they may be blue is because this blue blood that's coming in that should be going to the lungs, pardon me, cannot entirely go to the lungs. Maybe a little bit of it can go to the lungs, but the majority of it will actually sneak through this hole, this VSD or ventricular septal defect, and go out to the body. Now, whatever blood does make it into the lungs will go to the lungs, pick up oxygen, and return to the left side of the heart, and also go to the aorta. So the aorta is getting a combination of some direct blue blood that never made it to the lungs, and whatever blood did make it to the lungs through here does return to the left side of the heart and also joins into the aorta. And that mixture of red and blue coming out together is what determines what the oxygen saturation of the baby will be. If the baby has mostly red blood and not a lot of blue blood getting out the hole, then the baby will have very high oxygen saturations, close to normal, normal being 100 or high 90s. But if this area is so badly crowded that very, very little of the blue blood can make it out to the lungs, and the majority of the blue blood ends up coming out the aorta, then that's a lot of blue blood mixing in with only a little bit of the red blood, and that mixture together coming out the aorta makes for mostly blue rather than red, and causes the oxygen level to be very low. It could be in the 60s or 50s. And babies who have this problem can either get a full repair of tetralgia Fallot, completely correct that with an open heart surgery right away, or they can receive a type of shunt procedure, which is a way to get blood into the lungs through the back door, if you will, because they're the front door here, which is the right ventricular outflow tract, is so narrowed and crowded that blood can't get out that way, or insufficient blood gets out that way. And I'd like to bring up the name of these pioneers, Alfred Blalock and Helen Taussig, and Vivian Thomas. And the story of these three pioneers developing the first shunt procedure to correct tetralgia fallot is legendary now. And since the 1940s, when this procedure was developed, babies with tetralgia fallot have been saved. And the story of Vivian Thomas is also a fascinating one that I won't be able to go through in tremendous detail, but essentially he was someone that never received the appropriate credit because he was Black, and he never got the exposure and credit that he deserved for his contribution to this unbelievable paradigm-changing operation that was brought to children with congenital heart disease. But it was said that he was such a gifted technician and surgeon when he was doing these experiments in animals to prove that this could even be done, that he was the one that was standing behind Dr. Blaylock and whispering to him exactly where to put the stitches so he would know how to do the operation well. And it was said that his operations, Vivian Thomas's operations, were so perfect that it was almost like something that God made himself. The shunt looked like almost like a natural artery. And this is a movie that came out that you may have seen, and I recommend it if you haven't. So to get into what a shunt is briefly, it is a way of taking an artery that should be sending blood to the body and connecting it instead to the lungs. And what that does is this mixture of red and blue that's going out to the body, well, at least some of that blood, it doesn't matter if it's red and blue together, that blood, some of it, some quantity of blood now can enter the lungs, and it can go to the right and to the left lung and provide oxygen to that blood. And that makes it that there's more red now returning because there's more blue blood and red together getting into the lungs, coming back as red blood, and more of that mixture is going out to the body, which increases the proportion of red versus blue coming out to the body and increases the oxygen level of the baby. That eventually is a temporary procedure. Eventually we go into a complete repair of tetralgia fallot, which involves closing the hole with a patch and then cutting open the narrowing of that right ventricular outflow tract. So if that whole area was very, very crowded like this and blood couldn't get through, the surgeon will cut across like this and open up that whole area and put a patch on top to really create a larger opening like this that can go out to the lungs. And patients are typically left with no valve there at all. That patch destroys the pulmonary valve, and this is that example I was talking about where you can actually live for years and decades without any valve, with free leakage of blood back to the heart, to the right ventricle, and yet do quite well. It doesn't last forever. Eventually, you do need to have a valve replacement, and that's typically done using either an artificial or combined artificial and natural tissue valve known as a bioprosthetic valve, or we can also do a transcatheter valve replacement. Now, let me talk about a cousin of tetralgia fallot, which is pulmonary teresia with VSD, where instead of tetralgia fallot having a narrowed but still present path to the lungs, in pulmonary teresia, there is no path there at all. The valve is completely absent. There is no connection there at all. Some people don't even have a pulmonary artery there at all. It's completely absent. The connection from here to here does nothing. It's out in outer space here. This condition is an extreme version of tetralgia fallot, if you will, because it's similar but with no connection. And that needs to be treated with the placement of a conduit. Most people, they just can't get that patch to put on top there because there is either such a string little pulmonary artery or there is none at all. So they get an artificial tube that's sewn in between the right ventricle and the lung arteries to send blood to the lungs. And that artificial tube is something that can be made of human valve tissue. We call that a homograft, homo because it comes from the same species. Or it can be made of animal tissues, or it can be made of artificial materials. And these are types of right ventricle to pulmonary artery conduits. This is a human cadaveric pulmonary valve from a child who passed away and gave away their valves for us to use them in heart surgery in other children. Or we can use animal-based tubes that have valves in them, or we can have artificial tubes made out of a cloth, a medical grade type of waterproof cloth with an animal valve inside of it. And these are conduits. Now, conduits eventually fail. So conduits is a tube with a valve in it to act as the pulmonary valve. That valve acts like the pulmonary valve. So it eventually can fail like a pulmonary valve would fail, with either narrowing, stenosis, or insufficiency, which is the leak, or both. And if the stenosis is very severe, we can sometimes balloon open those conduits with a balloon procedure, just like we would treat a natural pulmonary valve that fails to open well and is stuck. Insufficiency, where the valve is very leaky, again, can be watched for many years because we could live that way for a long time, but it does eventually require valve replacement. And that's where either a surgical replacement of the conduit is needed, take out that whole artificial tube and sew in an entire new one that has a larger valve inside of it, or we can do a catheter-based valve replacement into that conduit. And that's where an example like this comes up. This is a patient who has this is an injection in the right ventricle, and you can see this area here. It's a little bit hard to tell unless you're accustomed to seeing these things, but there is a narrowing here. You can see a little pinching of this area. And on the side view, this is a side view, you can see quite a bit of narrowing is more evident on this view. And so this is what it looks like to put in an artificial valve. This is a catheter-based procedure, which we can now do. It's been now just a little over 20 years that we now have this technology available for delivering a brand new heart valve by a catheter-based approach. And the first catheter-based valve replacement was performed in the year 2000 by Dr. Bonhoeffer in Paris. And now this has led to a pioneering new era in congenital heart disease treatment, where not just the pulmonary valve, but other valves are being developed to be delivered by a catheter-based approach inside the heart, avoiding open heart surgery. Now, this is the end of the procedure where you can inject dye here, and you see that this valve is in place with no leak back. The valve has caused a greater opening. That metal mesh or stent pries open the narrowing that was there before, but at the same time places in an artificial valve and doesn't allow any leak back. So we treat both the narrowing and the leaking when we place an artificial valve like this. I'll spend a few minutes on aortic valve disease, and then I'll open the floor to questions. The aortic valve is another valve that's very important in the heart, and a bicuspid aortic valve is the most common of all congenital heart defects. In fact, in many textbooks and other places, having a bicuspid valve isn't even considered a congenital heart defect because it can be that common. And like any valve, it has to open and close. Those are the only two jobs of the valve. And if it doesn't open well, that's called stenosis. And if it doesn't close well, that's called insufficiency or regurgitation. And the patient can also have both, narrowing and leaking. So if you look at an aortic valve, and if you were to take the aortic valve and look down at it down the barrel like this, it would look like a Mercedes-Benz sign because it has three leaflets, 1, 2, and 3. And those three leaflets on the left side here, when they close, they make a nice seal with each other. When the valve is blown open like this, each of these three leaflets pushes aside and leads to a pretty wide opening, as you can see. This would be the effective opening of the aortic valve. When all three leaflets have been moved aside, you get a nice central opening here, and then it closes back down again at the next heartbeat. When a valve is bicuspid, that means that effectively there are only 2 leaflets rather than 3. And that's because 2 of the 3 leaflets are fused to each other. So these 2 leaflets here are stuck to each other so that only this part and this part can open from each other, but this part cannot. So when the valve opens, you can see here, this is the type of opening we get. This leaflet pushes aside and comes out like this and opens up, but the other 2 leaflets are stuck to each other and cannot separate, and that leads to an opening that's smaller than normal because of this fusion. And an aortic balloon valvuloplasty is when we go in and balloon this valve and try to tear open that fused area to improve that opening of those leaflets, just like we would do for a pulmonary valve. So if the aortic narrowing or stenosis is very severe, we can do a balloon aortic valvuloplasty, and that's available for children and even young adults. In fact, this is even something we can do in a fetus nowadays if it's necessary, and that's one of the procedures that I do in my practice as well. Now, older adults who develop narrowing of the valve sometimes have a lot of calcium buildup inside that valve, and that calcium makes it hard like a rock. And ballooning it with a balloon wouldn't work very well because the valve would just be stuck and barely move. And so that's where an aortic valve replacement may be necessary. And that, again, thanks to the advances that have happened over the last 2 decades, can be done either by a surgery or nowadays by a catheter-based approach as well, where we can deliver a brand new heart valve into the heart with a catheter, minimally invasive type approach. Similarly, aortic insufficiency, where the valve does not make a good seal, if it's very severe, may need valve replacement. Right now, there is no good technology or solution to make the valve have a better seal with a catheter-based approach. It really is a valve replacement that's needed. And valve replacement can be done by a catheter-based approach, but not a correction of one's own valve to help it seal better. And of course, surgical valve replacement is also possible. So I will close by saying this is a brief overview of different kinds of heart conditions and how they can be treated, explaining what narrowing of a valve is, what leaking of a valve is, how we approach correction of these problems. I'd like to close by saying that it is really important for patients with congenital heart problems to stay in care. And to stay in care means, to continue the follow-up with your cardiologist. I hope that you have a good relationship with your cardiologist, that you can ask questions, that you can, have clarity about what's going on in the heart. I really do believe, it's certainly my philosophy, to make sure that patients who come see me and their families understand what's going on with their hearts. If anyone needs to know what's going on with your heart, you need to know what's going on with your heart. There's nothing I should know that you shouldn't know about your heart. And so I think it's important to try to demystify these things, to take away some of the jargon, to explain things as simply as possible so that anyone can understand them, and it doesn't require having an MD after your name to sort of be in the know about what's going on with your heart. But it is a partnership, and we can provide information and knowledge to you about how your heart is doing and how you can best live with your heart condition and how to have the best quality of life possible and when the right timing for any procedures might be. But the partnership requires that it be reciprocated with, staying in care. And that means that as a family, as a patient, you need to continue to see your cardiologist, have regular testing done, because really the aim for us is to discover problems before they cause symptoms. If you come to us saying that you're exhausted, you can barely climb a flight of stairs before getting terribly out of breath, it's possible that what's going on is something that's been going on for a long time, and that we could have discovered it long before with echocardiograms and treated the problem before it caused the symptoms. And that's really what the aim is, to keep the heart functioning as long as possible, as well as possible, by discovering problems before they become irreversible, so to speak. So staying in care for different people with heart problems means different things. It may mean, being faithful with taking the medications that your cardiologist recommends. It may mean taking antibiotics before going to the dentist or before having procedures done on your body to help prevent bacteria from seeding or getting lodged onto the valve and causing infections that we talked about earlier. It may be modification of what kind of activities you should or should not be doing. All of those things are things that need to be discussed between you and your cardiologist. And so please, if you do see your cardiologist, come armed with questions, come armed with things that you want to know about, because our goal, certainly it is my goal, to make sure that patients are as well informed as they can possibly be. And I really view this as a partnership where we can work together to really help your heart work as well as it can possibly work, and as long as it can possibly work that way. So I will pause here and take questions, and these could be something that you type into the chat, or feel free to let us know if you want to raise your hand. But I think what we'll have is Jody go through the chat and sort of curate the questions so that we can address them live here. So thank you again for your attention.
Thank you so much. There were a couple comments about how excellent this was, and I will double that. This was the most clear and perfect explanation of valve disease that I've ever heard. And so really thank you for that. You got comments in the chat box on that as well. One of our questions here, and please feel free to write your questions in the Q&A box. We have a couple questions. One that is here is valvular disease considered heart disease overall?
Yes, that's a great question. So a disease of a heart valve is considered heart disease overall. Sometimes disease sounds like a terrible thing. Disease sounds like, I don't know, something contagious, or, sometimes the word disease sounds like something that is not really meant to be. Disease just means it's not functioning the way it should. And when the heart isn't functioning the way it should, sure, that can be caused by a heart valve problem, but some people have completely normal valves and it's the heart muscle that doesn't squeeze well, for example. That's a different kind of heart disease. So heart disease disease can really affect any parts of the heart, and sometimes in combinations can affect a valve as well as the heart muscle, as well as arteries or veins that come in or out of the heart can be implicated as well. So yes, heart disease is a very kind of broad category that can involve any of these things.
Okay, and we have we had more comments come in about how clearly you explained the valves and everything. It just was really amazing to hear that. And but we have another question on what is a subaortic membrane and how does that affect the functioning of the valves?
Great. So a subaortic membrane is something that we can certainly do a deeper dive at another time. But in addition to having narrowing of a valve, for example, there are areas that are not involved in the valve tissue, those flaps that should open and close, but rather involve areas just below or just above. An area just below a valve is called a subvalve area because it's just below the valve. And a subvalve membrane or subvalve narrowing means that underneath the valve, there can be some tissue that crowds that area and causes blockage. Technically, the blockage is not at the valve itself. The valve may operate well, but the blockage is immediately below the valve. That's a common thing that can happen below the aortic valve. That would be called a subaortic narrowing or subaortic membrane. But it can also happen below the pulmonary valve where you have a subpulmonary narrowing. It can also happen above a valve. So for example, above the pulmonary valve or above the aortic valve, we can have something that we call supravalvar narrowing, which is above the valve, where the valve itself may be fine, but just above the valve, there can be a real pinching of the artery that comes out of the valve. So these are different types. There are subtle differences between an actual valve problem and a problem that's just below or above a valve. But those details are important because we wouldn't want to replace someone's heart valve if the main problem is their area just below the valve. If we can salvage someone's own valve, that's always best. And if we can cut away some tissue that's blocking below the valve and not have to replace the valve itself, that's always better.
Well, that's very helpful because I know a lot of us have been dealing with that issue, or we're told that issue is there and really don't understand it. So that is helpful. And like you said, maybe as we go further, we can talk about that more in a different webinar. Bart asked, how close are we to using bioabsorbable valves?
It's a great question. There's been a lot of work for several decades trying to develop valves that will be in some way bioabsorbable, bioresorbable, basically made of some sort of tissue material that can be put into our bodies, with the goal being that maybe our body's cells would infiltrate, would occupy that tissue and eventually replace that tissue with our own healthy cells so that they would be living valve leaflets that would be left over after some years of this process. Unfortunately, that really hasn't yet panned out. That's not to say that it isn't, a worthwhile endeavor. And of course, there are lots of brilliant people working on these problems. The unfortunate reality is that the materials that have been used so far for making valves that are designed to degrade or melt away and be replaced by our own tissues have, for the most part, kind of retracted over time. Instead of just melting away, but staying the sort of the same size and being replaced at the exact timing with our own tissues, often those leaflets that are meant to do this kind of retract away, pull away, scar away, and become like little nubbins like this that don't open or close well. And then tissue may replace into that, but it doesn't result in a good valve that works well. So more to come on that. I have no doubt that this will one day become an option, but there's nothing right now that allows us to grow our own valve tissue in a laboratory and put it into someone's heart. Although, again, I think that we will come to that.
We have, this one may be a quick answer, so I'm going to put this one a little ahead. How long do the Melody valve replacements last?
That's a great question. So the Melody valve is the example I gave of that valve that we put into the pulmonary position, often put inside a conduit between the right ventricle and the pulmonary arteries. And those valves have been incredibly durable. Nowadays, the way we do the valve placement is a little bit different than the way it was placed early on. And the images I showed were very, very early on. For clarity, nowadays we would put some heavy duty metal stents in there, metal meshes to kind of keep that conduit from squeezing itself back down with calcium and hardening of that tissue that develops over time. We would put lots of those stents in there, 2 or 3 sometimes, and then put the Melody valve inside of that. And when that whole area is properly reinforced and the conduit cannot squeeze itself back down and compress the Melody valve itself is an incredibly good and durable valve that can last many, many years. We have patients who have been going more than 10 years with the same valve. The valve's been around for 20 years, and some of those early patients who had the valve placed, especially if it wasn't placed with a stent beforehand, have led to the valve fracturing and having to be replaced again. But with the more recent way in which we do this, the valve is now very, very, very durable.
We have several more questions. So what I want to ask one more that's on here because I think it's several people had interest in this. But I would want to say, if it's okay with you, Dr. Justino, we'll copy the questions and answers and send the answers out to the whole group after this webinar with the recording. Is that okay?
That sounds great. Absolutely.
Okay. This one is, Michelle asked, is it possible to replace a mitral valve with a transcatheter procedure?
That's a great question. So right now, there are no FDA-approved transcatheter mitral valve replacements. We have FDA-approved solutions for replacing the pulmonary valve and the aortic valve with a catheter-based option, but there are no approved options for fully replacing a mitral or a tricuspid valve. That's not to say that it won't come again in the future. There's a lot of enthusiasm for this and a lot of energy behind this, and a lot of investment has been poured into many different companies who are developing this kind of technology. So yes, I think it will come, but for right now, there are techniques for if you're an adult or an older, like a teenager, and there's predominantly a leak of the valve, there are techniques to try to clip or attach the valve leaflets and help them make a better seal. That can be done by catheter approach, but not a full replacement of the valve. Right now, valve replacement still involves surgery to replace it, or conceivably surgery to repair the valve. Our goal with any valve option that it's fair to bring this up as part of the question and answer here, is to say that if we can possibly keep you going with your own valve, that's always better. And the reason is this: anytime that we replace a valve, there is no valve that we can give someone nowadays that we say the valve is so durable that it will last 80 or 100 or 120 years. So you can give it to someone who's a child and they'll be fine for their whole lives with this one valve. There is no such technology available. So the reality is this: if we replace a valve and put in any kind of artificial heart valve, it's not made of living tissue of our own, and it will never last forever. It will wear and tear, and after a while, it will either not open so well or not close so well, or both, and will need to be replaced again. So when we give someone an artificial valve, in a way, the clock starts ticking on that valve. If I give you a valve now, and I know it's going to last 10 or 15 years, we can already say that, you know, in 10 or 15 years, you'll be back to potentially have another valve replacement. And if we do that very early on in a young child, we're looking at numerous procedures to keep replacing that valve over and over again till they, you know, live to be 100 or 120 years old or something like that, right? So the idea that trying to live with your own valve is really, really important, because your own valve, even if it's not made normally, if it can be improved upon surgically or some other way to keep that valve going longer, it is made of living tissue, and it can last a very long time, and a correction sometimes can allow you that valve to go on for 50 or 60 years or longer, much more than a valve replacement would.
Thank you so much. I mean, these were just excellent answers. We do have more questions, and I will send that out to all of you all with the link to the recording. We will have that recording on our YouTube channel as soon as possible and send it to all of you, and also be posting it on social media. We would like to thank you again so much, Dr. Justino. This was, I can't even say enough. I learned so much today, and I've been in this kind of CHD world since 2003 when my son was born, and I learned so much today. I also like to again thank Medtronic for their educational grant that allowed us to do this today. And so we will say goodbye to all of you. Thank you for attending. We really appreciate you being here with us today. Bye, everyone.
Thank you.